Okay, so this is a recurrent retinal detachment. This is a patient that's had a buccal vitrectomy previously and has a persistent or recurrent retinal detachment. Could not find the break in clinic, nor could I find it actually in the operating room as I was operating. So this is how I approach a case like this. Patient's already got a low-lying buccal on their eye. Probably wouldn't revise that, as it does give some help and some assistance. We're doing the core vitrectomy and now a depressed peripheral exam, trying to find that break. And some of the fluid had guttered around this anterior to the laser here. I suspect that the break's someplace supratemporal because the detachment's localized supratemporal, whether it's coming from a small break posterior to the laser that you'll see here in just a bit, or whether it's something that we just don't find. Regardless, I'll go ahead and make a draining retinotomy. If I don't find the break and can't drain through the break, I'll make a draining retinotomy. I, by far, like to make my draining retinotomies superinasal to avoid epiretinal membrane formation, but in this case, I have to make it supratemporal. I roll the eye so that I try to get a single bubble. This just helps with visualization. And I have my soft tip right over my draining retinotomy here. I'll start out doing fluid and trying to drain some of the fluid through the draining retinotomy before going to air, and then go to air. And once the air hits the retina, then I'll start to drain through the draining retinotomy in a shallow detachment like this. I'll go back and forth from the nerve to the draining retinotomy several times to make sure that it's drained as flat as possible. In this case, I really didn't get it totally flat, so I decided that since it's flat anteriorly, I'm going to go ahead and do that laser and allow a little bit more of that vitreous base to dehydrate and let some of that fluid to settle. So I'm going to go ahead and perform a laser anterior to the previous laser because that's where some of the subretinal fluid was guttering around from or to. And I'm going to go posterior to the previous laser with about a row or so. This is all sped up for time's sake. And I decided in this case to go ahead and do 360 laser. This is patient's second surgery, and so we want to be able to basically get things fixed for her. We'll go back over now our draining retinotomy and then drain any fluid over the optic nerve. And now I can get nice, concise laser right around that draining retinotomy. Just one row is all that's needed. And then we'll go ahead and add some laser to the nasal portion of the buccal here, just because I don't want to miss anything as far as that goes. I'll do a gas-air exchange. I like this little chimney that allows us to vent gas out. And once again, with 25-gauge cannulas, expect nice self-sealing sclerotomies. Thanks for watching.